Okay, this podcast is a bit heady. It's about ligaments of the upper cervical spine, how they're important, if they're injured, what structures they protect, and all of that nerdy, geeky stuff. Super important, but not the most exciting thing in the world. So if you're interested, I hope you enjoy it. If not, wait for the next podcast to come out. Thanks. Hi there, I'm Dr. Kevin Leach here with the Chiropractic Deep Dive Podcast, bringing you the most important research and information on conservative primary spine care, upper cervical chiropractic care, and traditional chiropractic care. These research reviews, interviews, and episodes are made for you, whether you're a medical doctor, patient, or concerned family member or friend. The goal of these shows is to bring awareness of the importance of taking care of our spine and the impact it has on our health and the hundreds of different health conditions it could cause without us realizing it. I'm really trying to bring value with these, so I'd appreciate commenting on the videos, hitting the like button, and sharing them with as many people as you can. You never know who might need to see it. And consider subscribing to the channel so you can see all the other episodes and videos coming out. Thank you so much. I truly appreciate your support. Now on to the show. Okay, welcome back everyone to the Upper Cervical Chiropractic Research Show. This is episode number 15. I am Dr. Kevin Leach. I'm your host, and by now, my good friend and colleague, Dr. Tyler Evans, is probably the co-host. We haven't really made anything official, but you've pretty much done almost every single one here with me. And he is also here today. So welcome, Tyler.
Thank you.
Awesome.
I look forward to this one.
Yeah, me too. This one, so Tyler, this is a paper that you really wanted to do. You recommended it for one of the next ones that we do here. The title of the paper is Ligaments of the Craniocervical Junction, a review, and this is by Tubbs et al., and it was published in the Journal of Neurosurgery. So this is a neurosurgeon who published this, and what the paper pretty much does is it brings together a lot of other research to really go into what's going on with the ligaments and other structures that are going on with the craniocervical junction. So where the head meets the top bones in the neck. And he goes over the importance of it, the biomechanics, the anatomy, and really goes over that. And you, sir, wanted to go over this. Why don't you just tell the audience why you feel this paper was important and really important for not only patients, but doctors and upper cervical chiropractic, just for everybody to understand the importance of this.
Sure. So I think it's really important to understand that the craniocervical junction, so cranium, skull, cervical spine, like the upper cervical spine here, the junction between the two is where they connect. And that's where Dr. Leach and I work every day. That's what we do. We correct that upper cervical spine to take, release tension and allow for the messages and signals from the brain down to the body back up to the brain, to be as clear and open as possible, as well as the blood flow, the cerebral spinal fluid flow. And in this paper, we're going to talk about the ligaments and how they play a role in all that. And, this paper actually came to me back in 2014 or 15 from the upper cervical diplomate program that I did. And it was a really foundational piece in that program. We actually, it was on our final exam. And so today when I was reviewing the paper, I was like, oh man, this takes me back. So it was a lot of fun to go back and review this stuff. But it's funny how now, going back, looking at it again after another 5 years or 6 years of experience, it really, there's some new things that I got out of it and just good reminders. And so this podcast is for anyone who is just interested in what upper cervical chiropractors do and how they help, but two, people who have been in car accidents or kind of intense head and neck trauma, or just have had repetitive head and neck trauma and they're suffering from kind of like post-concussion syndrome, what we call craniocervical syndrome, and they're not getting a lot of answers. This is where we really shine in the upper cervical profession within chiropractic, because when we talk about the upper cervical spine, it's the most complex joint in the spine. This paper actually outlines, it says, the atlanto-occipital and atlanto-axial joints house the spinal cord, multiple cranial nerves, and many important blood and lymphatic vessels that supply the head and neck. The CCJ must protect its contents while simultaneously allowing significant mobility. So it's got to be mobile, and it's got to protect the spinal cord, the brainstem. And so that needs a specific correction, and that's what we do. And we want to stabilize that joint, because this joint is made of muscles, ligaments, and tendons. It is not held together by bony locks like the rest of the joints lower down below C2. And so that's where this paper comes in. They talk about two main ligaments, the one being the transverse ligament, and the second one being the alar ligaments that limit a lot of motion there. They're very, I believe it's collagenous. There's a lot of collagen in them, so it makes them very dense and very stiff. The other 9 ligaments that are discussed in this paper are what we call accessory ligaments, and just kind of help those other 2 ligaments limit motion. And really one of them, the apical ligament, may even just be left over from remnants of evolution, and they didn't even really have a reason why it's there. And one of the ligaments, the posterior atlanto-occipital membrane, actually attaches and is what we call a myodural bridge from a muscle, the rectus capitis posterior minor at the base of the skull. From that outside muscle all the way through, goes through the ligaments and attaches into the dura of the spinal cord, which that's a big deal, because if the bone is off and that ligament attaches to the bone, it attaches to the muscle, and there's tension in that muscle, that's where upper cervical chiropractors, that's where craniosacral therapists and massage therapists come in huge, when you are working to relax those muscles, balance the joints, to take pressure off the brainstem and the spinal cord, so that the brain can heal and the nervous system can heal. And so that's where upper cervical really comes in. And it was interesting because, you know, they talk about the PAO membrane, and they say, well, it doesn't really have much value. And I'm like, that's what we do. Right? That's where we fit in. So anyways, real quick, that was kind of my summary. I just want to run through some of this stuff, kind of pick apart some of the ligaments, the 2 main ones, the alars and the transverse, off the top, and then I'll talk about the other 9 ones in brief. So the kind of biomechanics of the CCJ. The CCJ is composed of the 2 major joints. We talked about that. Prominent movement at the AO joint, so the atlanto-occipital joint between the skull and C1, is a flexion and extension. So this movement, flexion and extension, that's the primary movement there. The primary movement at the atlanto-axial joint is rotation. And so the numbers that we get from this for the flexion and extension, let's see, it's the various movements at the joint occur because the condyles glide in the sockets of the atlas, and that's flexion and extension. Occiput to atlas. Punjabi et al. Found the atlanto-occipital joint to be responsible for 27 degrees of flexion and 24.9 degrees of extension. And then a little bit of, it was 8 degrees of axial rotation there at C1 under the occiput, under the skull. And then down further, we talk about the atlanto-axial joint. We actually have mostly rotation there. And that joint we found between, let's see, atlanto-axial rotation was 23 to 38.9 degrees. And that, then if you take those two make up, so between the occiput and C1 and C2, we have roughly 50% of the range of motion in the cervical spine comes from how that head moves on that top neck joint. And so that's really important when we're talking about function of the body and just alignment in general. If that upper neck is out of place, it's going to translate all the way down the spine, and cause issues even down into the lower spine, hips and legs. The first ligament we want to discuss here is the transverse ligament, which holds the dens, which is this vertical bone here. It's C2. It's the pike that the ring of C1, this back piece here and the front piece here, sit on top of. And there's a little synovial disc between the two bones right there. And this transverse ligament is right here, this kind of thicker blue area right here. And what it does is it limits the motion of C1 forward away from the den. So that's flexion away from that bone. And that's really important because one of the things that we actually work with all the time in chiropractic is we're trying to reduce the anterior motion or rotation of that bone away from C2. And so if you understand where it sits and the problems that can arise with it, which they actually talk about later on in the paper, and I'll just kind of add this in here so we don't have to hit it later, but rheumatoid arthritis is where a lot of people will run into issues with that ligament, where it will get inflamed and degenerated. I actually see it a lot on what we do is called cone beam CT in our office, where we take a 3D dental x-ray, and you can actually see that ligament as you can slice through and see when that ligament has ossified and hardened on the back of the dens. And so it's something that we're taking into account in terms of how we care for people. It's really, really important that that ligament, it maintains its structure because it's one of the strongest ligaments in the spine. It's actually the strongest ligament in the craniocervical junction, which is important to know. And second to that are the alar ligaments, which actually attach, let's see, are they on here? No, they wouldn't be on there. They are on this one here. So what they do is they're called the Cch Ligaments, so alars here. So what they limit is lateral flexion and rotation, where the head is bending side to side or turning. They're actually limiting the movement of the skull away from C2 and the cervical spine, because they attach down from the base, like up inside of the skull here in this, what we call the foramen magnum. They actually attach right up here at the base of it, this hole, and attach down at that dens, that top of that bone here that I was telling you about a minute ago. And they limit movement. So if you tip your head one way, the one on the other side, so the one on the other way away from where you're moving, actually gets tight and holds that dens to the skull. Now, if there's a problem with that, in a lot of accidents and injuries where someone might have their head turned in a car accident or a fall where they hit their head, that ligament can be damaged. And so, it's really important that if there has been a head or neck injury, we do something called T2 weighted MRI, where, and I always remember this from my diplomate days, we would talk about T2 MRIs, or like the Terminator T2, the one that is mostly, he looks like water. And that's how we know a T2 weighted MRI is where we're looking at water in the image. And so you'll see ligaments light up more. And if they're dark or if they're black, they're separated. And that's bad. That's really bad. And you'll see that sometimes in alar ligaments. And a lot of people, they have these big car accidents and injuries where they don't have a lot of evidence to support, what they're feeling and what they're going through. But then if you do one of these T2 weighted MRIs and look at their alar ligaments, and their alar ligaments might actually be completely separated or blown, as Dr. Rosa said a lot in our program. And that is a court case winner right there. I mean, if those ligaments are gone, that's a really important thing to document. So just in terms of car accidents, that's a big deal. That limits that rotation, lateral bending of the head and the neck. And that's something that we're not looking at it on a regular basis in our chiropractic offices, but if there's a problem, we know to look for that. So one way that we can in our chiropractic offices is we can do lateral bending, APOMs, AP open mouths, where we're actually, the person opens their mouth and then you have them tilt their head, and you can see C1 would slip off of C2 quite a bit on one side, and that would open that up for quite a bit of movement. And so that's just something that we look at, and we're keeping an eye on in terms of craniocervical junction instability. And so one of the main points here of the paper is that there are other ligaments. There are 9 other ligaments, but those 2 are the mainstays of the cervical spine, of the upper cervical spine. There are 9 others, and they go from the, let's see, the transverse occipital ligament, which is a tiny little guy that actually sits right behind, you can actually see it here in the picture, transverse occipital ligament that sits right behind the dens, and that is actually attaching from the base of the occiput on one side over to the other side, and that limits some more of that extension and flexion, holding things in place there. And then let's see, it's TOL is a small accessory ligament of the CCJ located posterior superior to the alar ligaments in the odontoid process. Yeah, just it limits, let's see, sought to have similar functions to alar ligaments, limits lateral flexion and possible rotation as well. So good to know there. And then the accessory atlantoaxial ligament, this one was kind of an interesting one to me because I forgot about it, but what it does is it actually attaches down lower on the base of C2 and goes all the way up into the skull and attaches on C1. So it literally holds everything together and stabilizes it all together in flexion and extension. And so that's important to know. And they even said that this structure may be important for conveying blood supply to the base of C2 or the top of C2 area. And then let's see, the lateral atlanto-occipital ligament. This one here is, let's see, oh yeah, the lateral guy. This one was another kind of funny one. And what was interesting about this guy, so it's this guy right here, this is out on the transverse process of C1. So this is looking all the way out on the edge, and it attaches from C1 up to the base of the skull. I completely forgot that guy existed, but it sits right, I believe it's right behind this muscle here, which is called the medial rectus capitis lateralis. I didn't even know that muscle existed because I looked it up. It said it in the paper. And what's fascinating is this is another one of the little upper cervical muscles, the suboccipital muscles. These guys here, right there, these 4 muscles here, and then this guy right here, they are actually more, they don't do movement so much as they are sensory in nature and limit motion. And so they're all there to basically tell your brain where your head is sitting on C1 and C2. And so that little ligament, the lateral ligament there, the LAO, it's sending a lot of information into your brain about how C1 is sitting under your skull. And that ligament limits lateral bending of your head too. They kind of found that. So just fascinating stuff that I didn't even know that existed.
Before you continue, Doc, you know, when I was looking at this as well and just reviewing that exact ligament that you just talked about, I can't help but to think of one of the key concepts we look at in upper cervical chiropractic is laterality, meaning, for everyone listening, meaning which way the atlas has displaced left or right compared to the head and compared to the occiput. And so it makes me wonder if those ligaments would actually be able to be read with a T2 weighted MRI as injured as part of the mechanism of the misalignment that we're actually correcting. For example, if there's, you know, if there's a right laterality, is there damage to the left ligament or is there damage to the right? It makes you kind of think, well, and there's different, obviously there's different levels of sprains to a ligament. There's
Yeah.
there's 3 different levels, so it makes you wonder, when there's a misalignment, maybe it's only a grade 1. Maybe when there's a significant grade 2 or even a grade 3, I mean, that's when really, really bad things will happen. It just makes me kind of wonder. I wonder what that T2 MRI would say.
Yeah, and that's actually a good point. And I think what would probably be the outcome is just that the accessory ligaments are quite a bit less dense. So this is one of the accessory ligaments. It may be quite hard to see, and that might be why we don't talk about it too much. But again, it limits movement, and you may be able to pick it up on an MRI. I just haven't seen anyone talk about it or study it. So that might be something to look at. That's a good point, though, because that is an important piece to what we do. And then moving on to the Barkow's ligament, which is the 6th ligament in the 11 that we're studying here today. This ligament is located just anterior to the superior aspect of the dens. So there's actually a picture just for the Barkow's ligament. It's real small, and this is in the paper. But this little picture right here, so this little band that runs across from one side to the other. Now this is in front of the dens where the, oh gosh, what was the name of the other one? I believe it's the posterior, what was it? The
Transverse occipital?
Yeah, transverse occipital. That's actually posterior to the dens. Nice catch, Dr. Leach. So you can see that there's a lot of emphasis placed on this craniocervical junction to maintain the relationship of the dens to C1 to the base of the skull. There's all these tiny little ligaments that hold all of this together. And yeah, go ahead.
Yeah, one of the things that I saw while reviewing this that was super interesting is they talk about the Barkow ligament being, so it's like, so I'm going to use my coffee cup for the dens.
Yeah.
And so you've got your Barkow ligament that's on the front.
Mm-hmm.
And then what they say is that in order for that to actually do its job for holding things in place as we bend our head back, the transverse ligament behind it actually has to be intact. So
Yes.
Not only are these ligaments supporting structures and making sure we have mobility and stability, but they're actually working together.
Yes.
Which is just, I mean, it's crazy. It's incredible how amazing that is that they're actually working together to prevent that lack of motion, and just how intricately they all work together to give us the mobility we have while protecting all the structures in there. And it's just incredible. It's just incredible.
That's a great point. That actually was, yeah, that's in there. I remember that. So good catch. Yeah, and that one mostly limits flexion and extension, right? Flexion.
So yeah, I think it's the Barkow is for the extension. But for it to not go too far, that transverse ligament has to be behind it, right, intact, in order for it to, because if it wasn't there, then there wouldn't be anything for that pressure to anchor on, and it would just keep going back.
Yeah, which would not be good, right? Because that dens is sitting right there, and it's right by your base of your brainstem. So if that dens slips back, that's right in the brainstem. So your body,
nothing good it will come from that.
Yeah, your body is protecting yourself there. Yeah. So then we have number 7 is the apical ligament. The apical ligament is this tiny little ligament right here, which is actually probably not the best picture to use. Here, so I can see it. Right there, that little guy right there, and just behind the transverse occipital ligament. And what that guy does, so if we look at it from this picture here, this is a better picture. You can see right here from the dens up to the base of the skull. That guy, again, limits motion. However, they actually said in the paper that it's not taught in most of the cadavers that they studied. Well, maybe in real life it is, but in the cadavers that they studied, I believe that most of the time it wasn't even really holding tension. So they kind of said, well, it probably doesn't have much reason to be there these days, but I'm a believer that the body has everything for a purpose, and Again, that motion, it would limit. I mean, it's there to stop motion going forward.
Yeah, even if it's a backup.
Yeah.
Right? It's gonna prevent excess motion. So
right, exactly. And so that's kind of how like you and I look at stuff of, well, it's there at least to prevent big injury.
Right.
There might be a problem because you and I look at millimeters of misalignment, millimeters of problems, where if there's a few millimeters of play, it may not be a medical problem, but to you and I, that's millimeters of brainstem pressure, right? That's a problem.
Yep.
So all right, so that's the apical ligament. And then number 8 is the tectorial membrane. So this is the big it's like a big flowing cover that goes on the back of the anterior portion of the cervical spine. And what it does is it lays, so it's like this, it's the orange one or kind of red colored one here. And that lays across all of these other ligaments to kind of glue them onto the bone and hold them on there together so that they play together. And it's made up of a little different structure. Let's see, description of the tectorial membrane are insufficient and inconsistent with regard to anatomy and function. Some authors have reported this membrane is an accessory ligament that restricts flexion. Others describe it as a primary stabilizer of the CCJ resisting extension. So basically, they just couldn't come to an agreement based on all the papers that they reviewed, like what it actually does. It's there again. It's kind of holding everything together. It's the glue on the back of the front of the canal. So you've got here's the hole, right? And so here you've got all of those ligaments we were talking about on the front of the cord in the canal. And then it lays on that. And then you have the spinal cord in the center, and then we have the back of the canal and the bones on the back of the canal. So then we talk about number 9 is the.
Can I say one more thing about that? I think this is super important to understand. We're getting a little bit outside of the upper cervical spine, but the tectorial membrane, it says, Wernicke has also described the tectorial membrane as the well-developed superior continuation of the deep layer of the posterior longitudinal ligament.
Right.
Now, this is super important, especially in whiplash injuries, when we see an anterolisthesis or posterior listhesis of the lower cervical spine. During whiplash, that posterior longitudinal ligament can be torn, and then you'll get a shifting. And that's another, again, either whether it's from radiographs or from MRI, to show injury in a med legal case to support the patient's, injury. Just kind of how it's, I just wanted to kind of mention how those are kind of one and the same. It's just a continuation of that. But it's super important structure of what gets damaged and what protects the lower cervical spine in head neck injuries and whiplash injuries.
Yeah, that's a good point. That was something that I noticed, and I'm glad you picked that up. I forgot about that. Good catch.
Yeah.
And the one of the last ones here, the POA membrane, so the posterior atlanto-occipital membrane. So this is that one that it's the myodural bridge, and it actually attaches from the base, so the top of the atlas to the base of the skull. And then it actually goes into the dura of the canal here and out to the rectus capitis posterior minor, which is this muscle here, out on the back of the out on the back of the bones. And so we talked about that earlier. But if that muscle is tight, if that bone is misaligned, that ligament actually attaches all the way into the dura, and that can affect the spinal cord. And so that's how we know, Dr. Leach and I are always checking people's low backs and their hips to see if their neck is misaligned. Well, that goes along with our dentate ligament theory that we talked about a long time ago in one of our other podcasts. And that all kind of goes together with how someone might get symptoms that go up into their head or go down into the lower part of their body. If that ligament is attaching into the cord itself, then you could have an issue in any one of the tracts of the spine that go up and down at that area. So by correcting that upper neck, you can literally change the entire neurology above or below. Were you going to say something, Dr. Leach?
Yeah, I was curious. Why wouldn't they have on the picture here the myodural bridge going into the dura? Are they just focusing on ligaments? Is that kind of why they're not?
Yeah, well, I mean, there's papers on that. We can do a paper on that in the future. They just didn't show it, but yeah, they actually talk about it. So there's a part here where they say it's in the kind of breakdown later on of the importance of. Let's see.
Now, is that myodural bridge, is that just another function of stability and control to make sure things aren't compressed and to anchor? And
yeah,
it seems like it would be important on flexion to make sure that the spinal cord and brainstem don't get bent. It's almost like anchoring it, like almost like from a superior aspect, like a tent kind of thing.
Yeah. And I think there's a lot of place put on this that is more signaling to the brain about where the bones are at in place. And so it can tell, it gives input into the brain. Unfortunately, in these big head and neck injuries, it gives bad information. And that's what we want to fix. That's what upper cervical chiropractors want to fix, and reduce that tension at the bone and the spine. But their comment here was a study conducted by Hackett al. Reported the presence of a connective tissue bridge joining the rectus capitis posterior minor muscle to the spinal dura in all cadaveric specimens. And then this other guy found connective tissue bridge to be present in 67% of cadavers, indicating that this represents normal anatomy rather than a rare anatomical anomaly, which is really cool to hear because that's what we do. That's where we live. That's what we do. And we see changes in hips and low back all the time. We see changes in the mid spine. We see changes in brain function. And so if there is a ligament that's attaching all the way into the dura, well, that could be a big reason as to one of the big reasons why we're seeing changes elsewhere in the body when we correct the upper neck. Okay, so that said, the anterior atlanto-occipital membrane, this guy right here. So this big guy right up here. So it attaches from the front of C1, so the what's called the anterior arch, up to the base of the front of the skull. That ligament, or membrane as it's called, is a thin structure that attaches the anterior aspect of the atlas to the anterior rim of the foramen magnum. Says Tubbs et al. Noted that AAO membrane may function synergistically with the Barcal ligament to limit atlanto-occipital extension of the head. So again, that extension of the head, it's holding things down, kind of locking them down in the front. So there's a lot of strength and weight put on holding that C1 down to the dens and to the skull on that front end, because if things go backwards, that's not good. And that happens a lot in accidents, whiplash accidents. That's where people get really severe injuries and trauma, and that's why that ligament's there. So the nuchal ligament is the 11th ligament. The nuchal ligament is on the back of the cervical spine here, and we actually lower down when it goes into the thoracic spine, we call it the spinous ligament. And so this nuchal ligament is actually full of what they said. Intuitively, the nuchal ligament restricts hyperflexion of the cervical spine. Interestingly, some have identified a greater concentration of proprioceptive fibers in this structure and have opined that it may play a role in maintaining proper alignment of the cervical spine. So again, we're talking about information heading up into the skull, up into the brain. If the vertebrae are off, it's going to send bad information up into the brain, and that's what this ligament is doing. It's actually a kind of a GPS unit for where things are at in space. So That's an important thing to remember. Then it goes into histology of the craniocervical ligaments. So, you know, where they come from, how they're made. One of the important things they said in this little piece is just that the histology of these ligaments are that they are mainly composed of collagen fibers with minimal elastic fibers in their periphery. The degree of elastic tissue present varies from ligament to ligament. For example, the transverse and alar ligaments contain very few elastic fibers, which is why they're so dense and strong. They've got to be strong to prevent that movement. Okay, so with that said, then it goes into, you know, what are some of the problems that could happen. They discuss, you know, rheumatoid arthritis, Down syndrome, calcium pyrophosphate dihydrate crystal deposition, which I actually had a patient that had that. We identified it through our radiologist, Matthew Richardson, who's an amazing guy down in Palmer, Florida, Chiropractic College. He identified it, and we got that patient a medication. And I'm, you know, not a guy that tells people to go get on medication, but what's pretty cool is that was a life changer for that guy, because some of these problems, some of these more like autoimmune diseases, they are really tough. And you know, just a good review of the spine can give a lot of great information. And so we were able to help that gentleman in that situation. And then the last thing is whiplash, and they talk about whiplash for a big chunk of the paper here, and it just says that let's see, prevalence of whiplash associated disorders has drastically increased over the last 20 years or so. Basically that the CCJ is the most commonly injured joint in the spine during whiplash injuries. Alar and transverse ligaments are the most likely to be injured from a whiplash associated disorder. Trauma resulting in whiplash associated disorders often involves the transfer of large amounts of forces across the atlantoaxial joint, resulting in rupture of these two key ligaments. So just, you know, really important stuff there to know if you've been in a car accident or know someone that has and they're suffering from all kinds of symptoms and problems. Well, it very well likely could be that they've either had injury to these ligaments or they are stretched and there's a big misalignment in that craniocervical junction. And that's what we do. That's where we live. We want to balance that craniocervical junction to bring order and restore function back to the joint, so that the brain can communicate with the body again. And that's where we live. And you know, in this paper, they actually talk about how, well, so that rheumatoid arthritis is one of them, but a lot of times they'll talk about stabilizing C1 and C2 and the cervical spine to the skull. And it's like they say here, an anterior subluxation of the atlas is a big deal, and it may require surgical fixation. It's like, hey, what about trying to conservatively correct that misalignment, trying to conservatively reduce that? So that's what we do. So with all that said,
yeah, I think a good thing a couple things. And again, when they talk about subluxation in this paper, they're referring to a medical subluxation and not a chiropractic subluxation, meaning ligament laxity, meaning a displacement of the bone. When chiropractors talk about subluxation, if it's a full spine chiropractor, they're talking about more fixation and more of a stuck, immobile joint. And then upper cervical, we're talking about that, also that stuckness out of place, but not from a medical standpoint of ligament laxity. Maybe, you know, kind of to bring things full circle, maybe a slight ligament laxity, you know, just commenting about what we talked about before, as far as maybe there's a grade 1 or even smaller tear to the ligament that allows a slight displacement of that vertebra, but not to the degree where it would be diagnosed as a medical subluxation. That's number one. And the second thing, just to kind of review here, is, you know, you talked about craniosacral therapy earlier and massage therapy and then chiropractic, and it's important to understand the difference between all these. For the layperson, for medical doctors, what we're doing is not you know, something physical therapists do, massage therapists, soft tissue therapists of any kind. which is addressing, maybe the fascia or maybe the muscles, or just to get things functioning properly that way, whether there's adhesions and they're doing massage or trying to restore function that way. Especially as upper cervical chiropractors, we're dealing with the bones and the joints, and then the nerve function, whether it's coming from the joint or around the joint in the brainstem or the spine, or the spinal nerves or what have you. So it's important to know that all of these providers working together to figure out what the exact problem is the most important part. Because again, if we have these tiny injuries to these ligaments that are causing a misalignment in the upper cervical spine, which are causing problems with the patient, and that patient is only getting care to treat the muscles that are in spasm because they're trying to brace and protect the spine, you're just relaxing a muscle that the body is telling to spasm as a protective mechanism. Right. So the important, if we can get the alignment and the joints back into alignment and back to functioning properly, that in and of itself will allow a lot of the muscle and soft tissue to self-correct. But then there's always the, well, how long has it been there? Is more soft tissue therapy needed? So these cases, they can be pretty complex. And Dr. Evans, I'm sure you've had patients that have just literally gotten 100% better just by correcting their atlas. Tons of things get better. They're feeling phenomenal. But then you have other patients where you correct them, and then there's other things going on. Okay, let's get some massage in there. Let's get some soft tissue work, some physical therapy, whatever those may be. So I just kind of wanted to point out that there's a really important understanding of where the value of upper cervical chiropractic really comes in, as a missing piece for most people, most providers, to really know about the value of what it is that we're doing, and the intricacy. And obviously with these 11 ligaments just of the upper cervical spine, the importance, obviously, that we know that the body knows that we have in that area, with all these ligaments and stability, and the brainstem being right there, and it's just being an important area. Yeah, anything on that, Dr. Evans?
No, I think that's really important, and you covered it well.
Fantastic. Any closing comments about anything with this paper, about what people would like to know? I'll link the paper, or link a link to the paper in the description below for people to go find it so they can read it on their own. Any last input?
Maybe one thing I was calling back. I was talking about the APOM and open mouth, and just thinking back that it's the relationship between the dens and the atlas. You can see how the dens is moving inside of C1, not how C2 is slipping off of C3, or C1 slipping off of C2. But there are ligaments that you can look at, ligament damage there, and see if there's instability, and then you can then make maybe imaging protocols from that. Yeah.
Got it. Perfect. Fantastic. Okay. Well, thanks everybody for listening. Comment, like the video, share the video. We're trying to bring value as always, and let us know if there's any other papers or questions or anything that we can review in the future. Until then, thanks so much, and thank you, Dr. Evans, and we'll talk to you soon. Okay, that's it for this episode. So what did you learn that fascinated you or surprised you about the research today? Join or start the conversation in the comments below. Hey, thanks so much for watching. To watch more of our research shows, click or tap the screen right there. To subscribe to the channel, click or tap the screen right there. Until next time, I'm Dr. Kevin Leach with the Upper Cervical Chiropractic Research Show, bringing awareness to conservative primary spine care, upper cervical chiropractic care, and traditional chiropractic. Until next time, take care, and take care of your spine. It's the only one you'll ever have.